So you guys can all hear me. I'm tuned into a few different sources today, and we're going to be talking about GI. I am so excited to have you all here joining us. If you have any questions, no sound. Okay. Can you hear me now? Let's see here. Can you hear me now? Anybody in the chat? Are we good? Should be good. Okay, awesome. All right, let's get started, you guys. So we're here to talk a little bit about the GI system, and that's what we're going to go over. This is a, high-level boards prep, just a review. If there's anything today that kind of sticks that you're feeling doesn't go over super easy, and you have more questions about, go ahead and email us or sign up for some of our packages that we have. So the best way to get in touch with us always is going to be through that nurse practitioner um, dot nurse practitioner at archerreview.com. You'll get straight to Hiva, the director of our family nurse practitioner program, and she can help you, and as well as I can help you get anything that it is that you are needing. So please, please, please reach out to us if you need anything at all. We have some really cool offerings at Archer. I just want to talk about it really briefly. Our question bank. If there's anything that you take away from today, it's practice, practice, practice on those questions. If you are studying for your boards, the best, most important thing to do is to know how to approach those questions. We have our Q Bank. It's over 1,600 questions. It gives you a readiness predictor, which is really, really awesome. And the way that that readiness predictor works is the more that you take those exams, so you sit down, you're like, okay, I'm going to do a 75 question exam. You take it, it's going to tell you where you are. Now, if you just do it once, it may score you really high. That doesn't necessarily mean you're ready to go sit for your exam. That could be a little bit of a fluke that you got a little bit lucky, or perhaps you are just ready to go. However, the more you take that readiness test, the more accurate it's going to be at understanding whether or not you're going to pass when you sit down. So the way that I tell everybody to really study 25 to 50 questions every day, anything that seems hard that you answered incorrectly, go back and review that content. Then I would say taking a readiness predictor probably once per week for at least 4 times. And then again, using anything that you get wrong on that predictor test to really see what it is that you need, any areas of help that you need to review, content that just isn't quite there. Now, remember, these boards exams are looking to really get you into you're a novice nurse practitioner, but what the boards wants to do is make sure that you are a safe nurse practitioner. And so whenever answering questions, I always say go with the safest answer. That is the most important thing, okay? With our SurePass package, that includes the QBank on demand. It also includes a pass guarantee. So that, again, is dependent on how much time you spend on the product itself and really reviewing the content and using that readiness predictor or that test to really show where you're at and if you're ready. So if you're not familiar with our products, if you're getting ready for your boards and you don't know where to start, just take a look at what we have to offer. It's pretty great. We also do tutoring. Hiva and I have been super busy tutoring, which is one of my favorite things. One-on-one, we get to create these really great study plans for you and then go through question by question and understand where is it that you're kind of falling and where can we help as kind of pros in this area help you get ready to go. Okay, so let's jump into what we're here to talk about today. So our learning objectives, we're going to go over a brief review of the anatomy, talk about assessment and management strategies for the most common conditions, the things you're going to see on boards. And these are going to help you when you are out there actually practicing as well. All right, so without further ado, let's jump right in. Let's talk about our anatomy. I like to divide our anatomy into 4 quadrants. If you're a nurse, you are super familiar with the right upper, right lower, and left lower quadrants. This is our map for kind of telling us where the organs are located and describing whatever is going on accurately. It's really important that if you don't know that, go back, review it. Super common. way to describe somebody's pain. Okay. So in our right upper quadrant, we really the organs we have here, our major players are the liver, the gallbladder. They're really responsible for processing toxins and fats, help us digest those different things. We have our stomach nearby. That's going to handle our initial digestion, right? So our small intestine kind of goes from the upper quadrants down into the right lower quadrant. And that guy's really going to be important for absorbing our nutrients before it hands off our food or the bolus to the large intestine. That large intestine is going to pull out any extra water and really create stool. In the upper quadrant, we really have that pancreas. Important thing for releasing pancreatic enzymes, which help break down some of the food that we eat. It also regulates blood sugar. We have the beta cells that produce insulin. So when we're thinking about diabetes, we're thinking about injury to the beta cells or the pancreas. Um, then we have our spleen. We think our spleen is super, super important in that immunity response, and in particular in memory in our immunity. And then we have down in that left lower quadrant, the sigmoid colon, right? That descending colon, which is going to be the final kind of area to pull out water and really bulk up the stool. Right lower quadrant, we have the appendix. What is it responsible for? We think that it's responsible for something like the immune system as well, but we're not fully certain what it is. People seem to get infections in there, and sometimes those infections can cause an abscess or actually rupture into the peritoneal cavity, which would be peritonitis, can cause some pretty big problems. So it's really important that we always rule out something like an appendicitis if we're having pain in that right lower quadrant. So it's just something that should come to mind, right lower quadrant pain. Um, we should be thinking appendicitis. There's other things there, right? So we have to rule out other problems that could other organs or etiologies in that area, but one that should always come to mind when you think of right lower quadrant should most definitely be the appendix. All right, so here just another quick look. Left upper, left lower, right upper, right lower. Okay, when we're describing our findings, we're going to use these little acronyms, LUQ, LLQ, and that tells us where we're finding whatever it is that we're finding. Okay, so really important when we're talking about the exam on the abdomen that changes a little bit in the order that we're doing things. We have inspection, auscultation, percussion, palpation, and we follow this order to avoid disrupting the bowel sounds. Okay, so we want to look first. Okay, we're looking at seeing, I kind of like to stand to the side, kind of look at somebody's abdomen, see if there's any strange movements, any masses, distensions in some areas. Also looking for skin changes. Are there bruises? If there's bruises on the abdomen, that's almost always abnormal unless somebody could tell you exactly what caused the bruise. Otherwise, we're thinking of different things like liver damage going on, clotting disorders, something like that. What is causing this body to have bruising on that abdomen? It's just never, pretty much never normal. Okay, I always make sure that my patient's really, really comfortable. I put their knees kind of at a flex, so I have them kind of bend their knees when I'm going to examine them to help them kind of relax. And I tell them that, you can put your hand on your stomach as well, but I'm going to lift up the shirt, exposing as minimal amounts of their body as possible. But I do need to be able to look at to see what's going on. All right, first, after we do our inspection, we're going to next listen. The reason that we do that, again, is to not avoid disrupting any bowel sounds. So if I go and start percussing or palpating on the abdomen before I listen, I can wake up what would have otherwise been a sleeping bowel, and that would change a little bit about what I would think is going on. So when we are auscultating, we listen in each quadrant with a stethoscope, and we consider normal sounds to be kind of that low pitched gurgling sounds. 2 to 5 per minute sound is about right. So a little bit of going on, that's what we're looking for. If we have lots of sounds, if that bowel is just moving, 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 we consider it to be hyperactive. If we hear less than those, 2 to 3 sounds per minute, we would consider that to be hypoactive. No bowel sounds is known as absent bowel sounds, and that is very, very concerning. If you are not hearing anything going on, make sure that that should be a red flag, right? Things that I'm thinking about is some sort of an obstruction going on. But we can also get hyperactive depending on the level of obstruction, how long things have been obstructed. Okay, next we move to percussion. Percussion is kind of a lost art. I really think that this gives us value, especially if we're looking for any sort of mass or constipation, honestly. Um, if you, I just tell everybody, I use my middle finger and I use my other finger to tap on the top of my middle finger. There are different ways to do it. Some people use two fingers, but what you're doing is you're trying to elicit different sounds. And as you move over different areas of the abdomen, whether it's fluid filled, air filled, or a solid organ, then the sound or the that you create with that percussion changes. I like to kind of put that towards say you're trying to find a stud in your wall and you're looking for where that stud is. We have those kind of nice handy dandy little things that are stud finders. If you percuss a wall, you can hear when you've gone over air and when you get over the actual stud, the 2x4 or whatever in your wall. It's a great place to practice to start to tune your ears into hearing the changing of the sounds. You can do this on your partner, on yourself. Listen and start to get that art. It is so handy when you're working and you're trying to figure out what is going on with somebody, maybe in the primary care setting or in an urgent care type setting. So, GI, it has a really big list of etiologies or differential diagnoses. This is one tool that we have. So, I always say go for it and use it. All right, palpation. We start with light pressure. Again, this is when I have the knees bent because I don't want to think that somebody has some abdominal rigidity, which is indicative of some sort of peritonitis. I want to make sure they're feeling really relaxed. They can touch along with me, put their hands on top of my hands, and we're going to just slowly palpate. Now, if somebody has true abdominal rigidity, they are going to be tense and they don't want you to touch their abdomen. They may actually grab your hand and pull it away. Those things, which we call guarding, are really suggestive of some sort of inflammatory process happening in that area, whether it is because of acute appendicitis, diverticulitis, anything where we're starting to see inflammation happening. Okay. Then we're going to go into a more deep palpation. And what we're really looking for is masses. I had a patient who, unfortunately, she was diagnosed with breast cancer, came in to see me, and throughout her treatment, the cancer had spread and feeling, we already knew based on CT that she had masses in her abdomen. But it was just a really good reminder when I was seeing this patient and feeling her masses because she allowed me, she said, no, you can actually feel everything going on in there. And it's true. When there's something growing, that's why we do these palpations, is to really feel. And a mass is going to be kind of stuck to something. It's a little bit rigid kind of feeling. It doesn't feel like this nice smooth thing. And so you're going to go in with a really deep palpation in order to understand and appreciate any sort of changes that occur. Doing this exam is so important, even though you say it's always normal, it's always normal, it's always normal. The more that you are comfortable with normal, is the more likely you're going to be to find something that's abnormal. So if this is something you brush over on a patient exam and you decide, they're here for a physical, whatever, I'm not going to do their abdominal exam today, you're missing an opportunity to become really, really good for the next patient who might walk in and have something abnormal. So I say, take advantage, listen to the lung sounds, look in people's ears, look, feel their abdomens, do all of these things on the normal patient so that the moment that you find something that doesn't fit with what you're used to, you know that it's an abnormal finding. If you don't do these exams very often, you're going to miss something on a abnormal because you don't quite know. Again, really important for your exam, really important that you know that we're going to first inspect, then auscultate, then percuss, and final palpation. We are trying to eliminate and put our movement on that GI tract last. We're going to try to massage it last because that massage can kind of tune things up, wake things, turn things on that maybe weren't turned on, and that would kind of obscure our clues into what's going on with our patient. All right, GERD. This is such a common finding that we see. We think of acid reflux going on, you can see the risk factors here. So we always think about, is there something we can do? Modifiable risk factors. What's an example of a modifiable risk factor here? We can't change their age. Maybe we can address their weight, right? We can ask about different lifestyle changes that we can maybe do to help with their weight. If they've already tried all of that, maybe we consider sending to an obesity medicine specialist, or if we're comfortable with that, treating obesity in primary care. Super important. Don't ignore it. Hiatal hernias. Do we need to get involved GI here? Smoking. Can we help them quit smoking? Pregnancy. That's just kind of something we can't change. They're pregnant and they want to continue a pregnancy. We got to help figure out how to avoid the symptoms of acid reflux. NSAID use, are they popping a bunch of ibuprofen or meloxicam for some arthritis going on? If that's the case, we need to be protecting their GI tract from things like a GI bleed. Or just simply GERD at the early part, but we can get into a full ulcer and make things worse. If people are coming in to see you, hopefully they've already tried some of these diet modifications. Everybody like Googles things. So if they haven't tried any of these things, then we can go ahead and recommend them. Um, However, if they've already tried these things and they're coming to us, they're asking us for something to do about it. All right. So some of the common things that we think about, is that burning that happens here. However, if acid reflux is coming up, we can have silent reflux where we actually see erosion happening in their teeth. If you ask me, I'm not great at looking in somebody's teeth and telling you if there's erosion or not erosion. But who's really good at doing that is a dentist. And so I've had a patient come to me and say, "Hey, I don't feel like I have heartburn, but I was just at the dentist's office. Actually, it was across, just across the hallway from ours. And he said I have really severe erosion that he thinks is caused by a silent reflux. And so we're going to go ahead and treat that in the dentist is going to treat it. We're going to treat it in primary care. We can also just have a dry cough. If somebody wakes up with a cough, always think about that. Is it possible that they're getting some irritation in their throat? Maybe they're not appreciating the burn that a lot of people say, but they have some other of these signs and symptoms. Okay, red flags here, things not to miss. If somebody has difficulty or painful swallowing, if they feel really, really full easily, if they're losing weight, if they're tachycardic, all of those things, then those are red flag signs and symptoms. Depending on where they're at on that stability level, we may send them in for, is it an MI happening, right? Sometimes we can think that we're having GERD when actually it's a cardiac origin. So we need to rule those things out, absolutely. But if you're seeing anything like this, we're going to also get an EGD along with it. We can go ahead and when we're doing a physical exam and somebody has acid reflux, typically our physical exam is not going to come up with too much. They may have a little bit of epigastric pain when we're pushing there, and that would be indicative of maybe some early signs of an ulcer being caused by the overproduction of acid. Um, but we may not see anything, and that would be okay. So somebody tells us that they only have these symptoms. It's like when they lay down at night, nothing with exertion, no tachycardic symptoms or, no shortness of breath, anything that would be suggestive of an MI, we need to rule out because GERD and MI can look similar. I can't tell you how many patients go to the ER and they think they're having a heart attack and thank God it's just GERD. We can go ahead and treat that pretty easily. We have, again, our lifestyle changes that we can recommend. Always start there. But if they've already done that, so this is your history taking skills. If they've already done these things, they're really looking for what can we do? So we have our H2 blockers, we have our PPIs, and really what we want to think about here with our H2s is that they are a histamine receptor. And so therefore, I always think of the central nervous system. So if we give Benadryl or any sort of histamine type activation, what we can cause is some sort of a change in the central nervous system. So dizziness, confusion, and people who are more at risk for those things are going to be your elderly patients. So H2 blockers in the elderly, it's not your first choice, okay? And we have to be extra cautious in those. I think some of them fall on that Beers criteria and on the Beers list, and so we wouldn't necessarily be using it. PPIs, on the other hand, are something that are kind of our big guns. Like those are taking out our big guns. but they're going to do the most. And so if we have, depending on somebody's age, we are going to choose a PPI over an H2 blocker. We have the other things that are over the counter that folks can take. Something just to ask, what have you already tried? Now, most people will have already tried something like Tums or the antacids. And so they're coming to you because it's just not enough. All right. So lifestyle plus a PPI, maybe an H2 blocker, depending on their age. If they're elderly, I don't love anything that is an H2 blocker. Remember the H2s. I love this about medicine is a lot of times, most things we can tell by their endings. Okay. So the tadines, so famotidine, cimetidine, nizitidine, which I've never used. I just go with these two mostly. Ranitidine is off the market. We're not using that anymore. That was an old one. And then the prazols. So we have lansoprazole, omeprazole, or pantoprazole. Those guys, it's important to know the endings because on your test, this is just an easy to know, okay? PPIs, I think of P going in here, H2 blockers, the tadines. So write that down if you're not familiar with those things. PPIs, they do take a lot longer to work. I say up to 2 weeks to have the full effect. These guys irreversibly bind to our proton pumps and inhibit the release of hydrochloric acid into the stomach. So it takes a little bit longer to see a change, but these guys will do the best job. Whereas the H2 blockers, they're going to go in there and work immediately. We see this prior to a surgery. Sometimes they would give a bag of famotidine or cimetidine to go ahead and neutralize the stomach acids, right? So that reduce the risk of aspiration. I think of the H2 blockers, fast acting, work quickly, but we may need to dose multiple times a day. All right. And remember, with any sort of histamine effect, we could have a central nervous system side effect, which is why we'd be cautious in older folks. Okay. If we do everything we know, talked about lifestyle, prescribed PPIs, and we're still having issues. I also think about alcohol use. We talk about all of those things. If we can't figure this one out, then we're going to ask our friends over at GI to help us. And here are some interventions they may do. They'll start definitely with just doing a look down there. Nissen fundoplication is something else. Bariatric surgery might be on the list of something that we could consider if needed. All right, so just a quick practice question here. If we have a nurse practitioner who's prescribing medication for a 77-year-old with GERD, which of the following is going to be our first line therapy? So we have Pepto-Bismol, Tums, Pepcid, or Prevacid, and look at those endings. So we have famotidine, lansoprazole, are the two that I want you kind of focus on. And if you can, in the chat, go ahead and tell me which one would you choose? Let me know. All right. Good. If you said D, you are correct. And the reason we don't choose C, remember, is the risk of delirium, confusion, falls in our elderly people. Now, that's not never, ever, but for boards, we're not going to choose it as our first line. And if we have an elderly patient, we're going to treat this more aggressively because of the risk of complication from anything, right? So a little bit of acid reflux in an elderly person can get bad quickly, and so we're not going to recommend Tums. We're gonna pull out our bigger guns for an elderly person. The one thing to know just about Pepto-Bismol or the bismuth salts, it can cause constipation, and when we have geriatric patients, they're already at risk for constipation, sometimes related to their diet, water intake, and then overall just the peristalsis absorption and so forth going on in that GI tract. Okay, so I'm going to move on over to my next favorite is peptic ulcer. So we take GERD and we're going to just kind of push it up. We're going to dial it up a little bit now. So we have GERD that is not being treated, which can lead to something like a peptic ulcer. We can have a gastric ulcer where we're seeing an erosion of that protective mucosal lining leading to what we would call the ulceration, right? We can also have this occur in the small intestine. Some people can get them in the esophagus as well. We think of H. pylori or Helicobacter pylori, a bacteria, as kind of the most common cause of peptic ulcer disease. So we want to always be testing for that. Other risk factors, again, NSAID use, lots of ibuprofen, alcohol use. If we're going on some long binges or we're chronically drinking, then we can disrupt a little bit of that acid. Smoking, also really a pro-inflammatory, pro-acid thing. And then family history. So if it's, if it's in the family history, let's take a look and see. Okay, so how do we understand the location? I like this. This is something that we should know for the boards. But duodenal versus gastric, they will appear a little bit differently. Gastric pain, when we're eating, that pain is going to get worse, and it intensifies 2 to 3 hours after eating. And antacids, meh, not really too super helpful if that location of the ulceration is in the stomach itself. Okay, duodenal ulcers, we're going to see that kind of burning or gnawing pain kind of right here. I see more epigastric that comes in there, really, really starts to turn on at night when we're sleeping. And when we eat or take antacids, it does help just a little bit. So if somebody says, "Hey, when I eat, I feel a little bit better," we're going to initially just kind of go to more of a duodenal type ulceration. But our red flags here, anytime we see any sort of vomit with blood or stool with blood, severe abdominal pain, we're thinking about GI bleed. Now, that ulceration has gotten deeper to the point where we're exposing our vasculature and bleeding into the GI tract. So, if you're seeing that or you're hearing that, you're not treating these people in the primary care setting. We're going to get some help on that if we're concerned for a GI bleed. Okay, abdominal findings. Now, this is a little different than what we saw with our GERD. With GERD, remember, we said, not too much on our abdominal findings. Here, we're going to see more symptoms and pain when we're touching. That epigastric area is going to be a little bit more tender when we're pushing down there. And we can use a few different ways to kind of diagnose this. An EGD, so they go in with a scope and they actually look and see ulcerations happening, barium swallow. H. pylori testing. I love the H. pylori testing because if we have a bacteria in there that's causing this problem, then we need to get rid of it. However, if you've had a patient who has been on a PPI for in the last 2 weeks, they're treating themselves with over-the-counter Prilosec. Now they come in and you run an H. pylori test and you do a urea breath test for them. It comes back negative. We can't trust that. So the PPIs interact with the bacteria and can give us a false negative. Super important to remember. If your patient is on a PPI, we need to get them off of that before testing for H. pylori via the breath test. Okay. We can go ahead and look for, any sort of inflammation, any sort of anemia, if we have like a slow GI bleed that we're concerned about, all of that stuff. But again, red flags, if they're in a lot of pain, abdominal pain, we're not sitting there twiddling our thumbs and trying to figure out what's going on with them in the primary care. We're sending them over. They probably needed a CT or something, maybe an ultrasound right away to figure out what's going on, perhaps an emergent EGD as well. Abdominal rigidity, never, never, ever, ever normal. Tachycardia and abdominal rigidity together, big cause for concern. If you see that, they are out of your clinic. This is an ambulance ride to the ER. Okay. Um, Let's see here. So, how do we treat them? What are our goals? Well, we want to get rid of the symptoms, but we need to heal that mucosal lining. So, what's a better way to heal that than start at stopping the production of the acid and lowering the acidity of the stomach temporarily? We're going to also get rid of any of the agents that might be causing this. So, if they were on something like an NSAID or if they're on steroids and we can get them off of steroids, we're going to try and do those things and discontinue medications that might be causing the damage. But really, we're trying to promote healing. If it's an H. pylori infection. We're going to get rid of that bacteria. Okay. So we're going to eradicate that bacteria. We have these different options. I'm pretty sure, well, we have triple therapy and quad therapy. For practice, I would say just jump right to your quad therapy. That's a recent recommendation that came out from our body of gastroenterology folks. They said just go straight to that quad therapy, triple therapy on the boards exam. Knowing the difference between quad and triple is super important. So triple, I think of pack that ulcer, so PAC. So we have in both of them, we're going to have a PPI. PPI, you could choose any of them, pantoprazole, omeprazole. Doesn't matter. Just choose a PPI, get comfortable with one, know it, and go ahead and start that. That is going to be your longest guide because we're going to lower that acidity environment and allow for healing to occur. Okay, so you're going to choose your PPI. And then with the triple, it's amoxicillin and clarithromycin. Each one of these, as you can notice, has two different types of antibiotics that are going on here, plus a PPI. The quad therapy treat my belly pain. We do tetracycline. We also do metronidazole. So those are your two antibiotics. For the B, we're going to do the bismuth salt or Pepto-Bismol. Some people like sulcrophate, but something to kind of heal up that lining. So we're thinking about that. And then P is your PPI. So Protonix, if that's easy to remember, P, go for it. That's an awesome treatment. But for practice right now, quad therapy is the gold standard. Okay. And I don't know if you've learned anything different. You guys are all in school. So if you've learned anything different, let me know. But that is from what I read. I have a subscription to the AFP journal. And so that was something that came out maybe 6 months ago. And my time could be around, could be more than that. But let's say within the last year for sure, I read that. Okay, repeat urea breath testing. Absolutely. I do like to do a test of cure after I've treated with my quad therapy to make sure we got rid of it. However, remember, I need them to be off of that PPI for at least 2 weeks before I repeat this. So I'm not getting this repeat test typically for about 10 weeks after I start their therapy, because here's how it kind of looks. It's going to be 2 weeks of antibiotics, all right, along with the PPI and the bismuth salt. Then we are done with the antibiotics. We can continue that bismuth salt kind of PRN if they're having issues, but we can kind of probably be done with that as well. However, that PPI is our big hitter in kind of helping get that lining built back up. And so I'm going to continue that PPI 4 to 6 weeks. Okay. And then I don't stop a PPI abruptly. If I stop a PPI abruptly, what can happen is called rebound acid reflux, and they will not be happy with you. Okay. So we don't want to just discontinue it. We want to taper off. And so the way I taper off is over a course of 2 to 4 weeks, depending on how the patient tolerates that taper. And we go as slow as we need to get them off. And then we're going to repeat our test of cure once they're completely off of the PPI for a minimum of 2 weeks. If it's 4 weeks, I'm okay with that. People have lives. They might not get back in to see you right away, but make sure you get that test of cure, because if you don't, what can happen is that we just have the symptoms return. Most people they're gonna be hard to come back in, and you're not getting that repeat because they feel so good and they're like, meh, I don't need to come back in. So I always tell them at the beginning, I do want to get a test of cure. So I'll see you in about 8 to 10 weeks after we start that treatment, and maybe follow up in 2 weeks, just make sure they're doing okay. The biggest reason that people don't complete treatment is that antibiotic regimen is pretty intense and pretty hard on your gut. So give them a little bit of, anticipatory guidance, make sure they're taking it with food, and that they might not feel great, but it's so important that they complete the treatment. Okay. Our last question, and then we have to wrap up here for today. Your 54-year-old patient reports recently being hospitalized for a perforated peptic ulcer. In addition, he reports frequent use of over-the-counter pain medication for his osteoarthritic knee. What pain medication may cause a GI perforation? So what is it that they're going to get him? You are going to make sure he's no longer taking, or if he needs it, how can we best protect him? So is it ibuprofen, capsaicin? Is it that topical lidocaine that causes a GI perforation, or acetaminophen? Acetaminophen hit the news this week. Boy, oh boy. Okay. If you answered A, you are correct. A, that is our NSAID, and NSAIDs can disrupt. It's through that COX inhibitor system that it is causes more acid to be released and reduces the production of the prostaglandin mucosal protection. That is the pathway that happens here. So ibuprofen inhibits the prostaglandin production of mucus in the GI, and then we're not having that protective layer occurring, and therefore increase the risk of acid kind of starting to eat our own stomach, if you will. So we want to make sure if we're doing something like an ibuprofen on a regular basis, or some sort of NSAID, doesn't matter for whatever, you're also giving them a PPI to protect their stomach from ulcerations. Okay. Capsaicin, no concerns there. Lidocaine, this is topical, no concerns there. And acetaminophen, we don't see the GI effects from this medication. All right, guys, that is a wrap for today's GI review. I will next time talk more about the gastroenteritis, IBS, and IBD stuff. So tune in with me in October. We'll go through that. But again, these are just a review. If there was anything that didn't stick with you today, feel free, reach out to us. We love working with students. I love tutoring. So if you have some concerns and need some help, don't hesitate. We are here for you. Join our community, scan this guy, look at what this SurePass all includes, and we will see you again soon. All right. Always a pleasure. Good luck on your boards. Remember, you've got this. Choose the safest answers, and you're going to do great. Okay. We'll see you next time.